Welcome to today's Explainer. We're diving straight into a really fascinating yet incredibly complex neurological condition, Dandy-Walker malformation. If the wildly varying presentations or the highly debated surgical treatments have ever left you confused, you are absolutely in the right place. We are going to go point by point, breaking down everything from its initial development in utero all the way to patient prognosis, so you can totally clear up this concept without having to dig through a dense textbook. Let's get started.
Okay, let's dive into this. Here is exactly what we're going to cover today: defining the malformation, pathophysiology, risk factors and epidemiology, early medical treatment, the surgical management dilemma, and finally, patient prognosis.
All right, Section 1, defining Dandy-Walker malformation.
So what exactly is this condition? Well, Dandy-Walker malformation, or DWM for short, is a congenital brain malformation. Its hallmark characteristics are twofold. First, you have the agenesis, or the failure of development of the cerebellum vermis. Second, a distinctly cystic fourth ventricle. Understanding these two massive structural changes is absolutely crucial because it's the foundation for everything else we're going to talk about. Check out this beautiful watercolor-style medical illustration we've rendered from an MRI of a 29-year-old woman. Do you see that blue arrowhead? It's pointing right to the hypoplastic or underdeveloped cerebellar vermis. Right below and adjacent to it, you can clearly see the cystic fourth ventricle, labeled He4. Also, notice that distinct membrane sitting right between the cystic fourth ventricle and the cisterna magna. Seeing it visually like this really makes that definition we just went over click into place, doesn't it? Now this is where it gets super interesting. Let's look at a comparison. On the left, we've got DWM, but on the right, we're looking at something totally different, a megacisterna magna, or a posterior fossa arachnoid cyst. They can be incredibly tricky to tell apart in practice, but look closely at the watercolor image on the right. In that non-DWM brain, the cerebellar vermis still successfully forms a solid posterior border to the fourth ventricle. In the DWM image on the left, that border is completely disrupted because the vermis is missing or hypoplastic. That right there is your key diagnostic differentiator.
Moving right along to Section 2, pathophysiology.
So how does this actually happen in utero? Well, the exact cause is honestly still a bit of a mystery, though we do know it involves defective embryonic development, specifically dysembryogenesis of the roof of the rhombencephalon. Now, old textbooks used to say this was due to a failure of the fourth ventricle outlets. Actually, scratch that. We now know it's definitely not that. The medical community has completely updated its stance. The actual end result of this developmental defect is a massive posterior fossa cyst that actively communicates with an enlarged fourth ventricle.
And because of all those disrupted fluid dynamics, you get a pretty staggering statistic. Hydrocephalus occurs in 75 to 95% of all DWM cases. To put that into perspective, if you look at literally all cases of hydrocephalus globally, Dandy-Walker malformation accounts for 2 to 4% of the whole shebang. That is a massive clinical correlation.
Section 3, Risk Factors and Epidemiology. So who is most at risk and what triggers this? While most cases don't have a clear-cut genetic link, autosomal recessive inheritance has been identified in a few rare instances. It's also known to be associated with Faces syndrome. But the major predisposing factors are actually environmental exposures during gestation. We're talking about gestational exposure to infections like rubella, CMV, and toxoplasmosis. Plus, fetal exposure to substances and medications, specifically warfarin, alcohol, and isotretinoin, are all considered huge predisposing triggers.
Even with all those different risk factors, Dandy-Walker malformation is still pretty rare. The overall incidence rate sits at roughly 1 in every 25,000 to 35,000 live births.
Here's a really striking fact, though. When you break that incidence down by sex, a massive disparity pops up. The male-to-female ratio is 1 to 3. That means females are literally 3 times more likely to be born with DWM than males.
That brings us to Section 4, early medical treatment.
Okay, so how do we actually treat this from day one? Non-surgical management is highly focused on symptoms. If the patient has seizures, we get them right on anti-seizure medication. Physical therapy and speech therapy are absolute staples to help aid overall development. And importantly, if there's ventriculomegaly, which is the enlargement of those ventricles, early treatment is highly recommended to give the child the absolute best chance at maximum cognitive development. But here's an interesting twist. If the infant does not present with hydrocephalus or signs of brainstem compression, the standard of care is actually expectant management, basically very careful observation, during that first year of life.
Why? Because that first year is the specific window when these patients will typically develop those severe symptoms if they're going to happen at all.
Section 5. The Surgical Management Dilemma.
Now we enter the most highly debated area of this whole clinical profile, surgery. It's a real dilemma, and we're going to walk through every option so you have the full picture. First up, a posterior fossa craniectomy with membrane excision. Honestly, this is less favored nowadays. It has a super high complication rate, and patients frequently end up needing a shunt later anyway. Second, lateral ventricular shunting alone. The huge caveat here is the risk of aqueductal stenosis afterwards. The cyst frequently just persists, and there's a really scary risk of upward cerebellar herniation. Third, shunting of the cyst alone. For this to even work, it requires the Sylvian aqueduct to be patent or completely unblocked. If it isn't, the supratentorial ventricles will dangerously enlarge. Continuing down our list, surgeons might also consider concurrent ventricular and cyst shunting, or sometimes just shunting the lateral ventricles alone. It totally depends on the specific fluid dynamics happening in that individual patient. The sixth option is an endoscopic third ventriculostomy, but again, a major caveat, this is only viable in cases where the aqueduct is completely patent. Finally, the seventh option is cyst fenestration, which is basically creating an opening in the cyst, but this is typically reserved for older patients. As you can see, every single one of these surgical choices is a really intense balancing act of severe risks and very specific anatomical prerequisites. There is no easy answer.
Finally, Section 6, Patient Prognosis and Outcomes.
So what does all of this mean for the patient's future? Historically, the pediatric neurosurgical literature has quoted mortality rates ranging anywhere from 12 to 50%. I know, that is a really grim statistic. But it's super important to note that the prognosis varies wildly depending on the severity of the malformation. And thankfully, these mortality rates are steadily improving today thanks to modern, much more advanced shunting techniques.
So, the absolutely crucial point here is this. Survivability is going up, but cognitive outcomes, they're literally a coin toss. Exactly 50% of patients with DWM will have a normal IQ. The other 50% will unfortunately experience below normal cognitive development.
Physically speaking, survivors often have a few specific neurological hurdles to manage throughout their lives. These commonly include ataxia, which is a lack of muscle coordination, spasticity, meaning stiff and rigid muscles, and generally pretty poor fine motor control.
On top of that, about 15% of patients will experience seizures long-term. This ties right back into why that early and ongoing anti-seizure medical management we talked about earlier is so vital. So let's wrap this all up. We've seen the anatomical proof in the watercolors, we've gone point by point through the developmental errors, and we've navigated that incredibly delicate minefield of surgical options. It leaves us with a profound clinical challenge. Given the huge variability in symptom severity and the highly controversial nature of the surgical interventions we just laid out, how do we best individualize treatment from day one to optimize those long-term cognitive and physical outcomes? It's a heavy question, and it's one that neurosurgeons have to grapple with every single time they spot that missing cerebellar vermis on an MRI. Thank you so much for joining me for this explainer. I really hope this deep dive helped clear up the complexities of Dandy-Walker malformation for you.